Welcome, everyone. I'm Dr. Richard Davis Batson, and today we have Dr. Cyrus Raji, medical doctor and PhD, who's going to be lecturing on the neuroradiology of traumatic brain injury. This is part of the neurotrauma evidence synthesis training, which is basically a mentorship program for students that are interested in traumatic brain injury and want to learn how to do literature reviews, evidence synthesis, systematic reviews, meta-analyses, and so forth pertaining to topics in the traumatic brain injury space. And part of this program is to bring on experts like Dr. Raji, who subspecialize in the area of traumatic brain injury and can help the different researchers learn about different topics in traumatic brain injury. We've now opened this up to a broader base to allow various individuals to attend, whether from different backgrounds, including other healthcare providers. And it's also sponsored by the Endocrine and Brain Injury Research Alliance, which is a group of physicians and scientists and researchers dedicated to looking at the long-term consequences and outcomes of traumatic brain injury. So without further ado, I'm going to read a short introduction to Dr. Raji's very long bio. Dr. Raji is a tenured associate professor of radiology and neurology at Washington University School of Medicine in St. Louis. He's the principal investigator in the Neuroimaging Labs Research Center at the Mallinckrodt Institute of Radiology. He's also the director of the Raji Brain Health Imaging Lab. He's the director of the neuromagnetic resonance imaging at Barnes Jewish Hospital, and he's an associate director of the diagnostic radiology residency research track. He attained his MD and PhD from the University of Pittsburgh School of Medicine and contributed to pioneering amyloid imaging research in Alzheimer's disease. He completed his residency at UCLA Medical Center, was the recipient of the RSNA Röntgen Award for Outstanding Radiological Research, and then he went on to complete a neuroradiology fellowship at UCSF, including an NIH-funded research on diffusion MRI in traumatic brain injury, and that's diffusion tensor imaging. He's board certified in both diagnostic radiology and neuroradiology. He's also focused on modifiable risk factors for dementia and quantitative neuroimaging of brain injury as well. He has over 100 peer-reviewed publications and has been cited over 6,000 times. We very much appreciate Dr. Raji being here today to lecture to our group. So Dr. Raji, thank you again.
Thank you, Dr. Batson, for the very kind introduction, and to everybody for joining this morning. If anybody can't hear me or can't see my screen, please let me know. Otherwise, I'm very happy to be speaking to you today about the neuroradiology of traumatic brain injury. This will be a two-part talk. Part one, we're going to be focusing more on conventional techniques, and then part two, we'll focus more on advanced techniques, and there'll be some bridging material at the end of this lecture. These are my disclosures. Both in terms of consulting as well as research support from the National Institutes of Health, Department of Defense. I'm not here to sell you anything or any products. And, Dr. Batson did a fantastic job overviewing my background, but I think it's also nice to just see how many mentors I've had in the field who are real pioneers, from Carolyn Meltzer to Bill Klunk, who invented amyloid imaging, Jim Becker and Oscar Lopez, Dr. Lopez being the director of the Alzheimer's Disease Research Center at the University of Pittsburgh. At UCLA, I did a lot of work with Paul Thompson on advanced neuroimaging analyses across different cohorts in research. And then at UC San Francisco, I worked with Dr. Pratik Mukherjee, who's really known for traumatic brain injury research, as well as being one of the key investigators on the TRACK TBI study. And since then, I've been doing a lot of work at Washington University in St. Louis, running my own laboratory, as Dr. Batson had mentioned. So again, it's been about a 25-year journey now so far, and a lot of great mentors and work that's been done along the way, and a lot more yet to come. We're going to be talking very briefly today about the epidemiology of traumatic brain injury, some of the severity attempts, looking at CAT scans or computed tomography or CT imaging of TBI, and then conventional magnetic resonance imaging of TBI as well. Now, in 2014 alone, there was an estimated 2.5 million TBI-related emergency room visits in the United States, including over 800,000 children. And when I'm in my own clinical practice and reading scans from our emergency room, by far trauma is the most common indication I see, whether it's motor vehicle collisions, direct assaults. And if we cured every disease that we could know of, from cancer to Alzheimer's disease to, genetic disease, trauma would still be something we would have to deal with as humans because we are neither immortal nor invulnerable. And the annual cost of TBI in the US, at least in the literature, was estimated at 76.5 billion. And, Glasgow Coma Scale, which is essentially different assessments of figuring out whether or not an individual is awake, alert, moving around, is a very blunt instrument for characterizing traumatic brain injury. And the characterizations of mild from 13 to 15, moderate, or severe are very broad categories. And so, for instance, if somebody has a severe Glasgow Coma Scale, they're essentially going into a coma system, right? It's called the Glasgow Coma Scale. It's not called the Glasgow TBI scale. And so somebody could have, a Glasgow Coma Scale that's perfect at 15 and still have a mild traumatic brain injury. The most common causes of TBI are falls and motor vehicle collisions. So even though there's a lot of attention on sports, professional football, that's not something we're going to be focusing on today. We're really focusing on the kind of, garden variety, day-to-day life reasons that we see TBI. And of course, in the acute setting, in the ER and trauma, day of accident, that's typically the acute TBI timeline. Subacute TBI is less than 3 months out, and chronic TBI is actually considered greater than 3 months out. And, there's a whole, debate. This article is now 10 years old, titled Concussion is Confusing Us All in Practical Neurology. But concussion, even though it's designated as a mild traumatic brain injury, it does impair brain function, and it's due to an externally applied force to the brain. It can be a direct blow, it could be a sudden jolt, it could be a rapid acceleration or deceleration force that typically occurs in a motor vehicle collision. So the external force isn't the same as it being a direct impact to the brain, although it can certainly include that. But for instance, somebody riding a speedboat that then jolts on the surface of the water, that could conceivably lead to traumatic brain injury, for example, and a concussion or mild TBI. And so the idea is that with concussion, we can't see any visually evident structural damage to the brain, although, as I'll show you, you can certainly quantify with advanced imaging, evidence of damage even beyond what's visually evident. And the symptoms can include headache, dizziness, sleep disturbance, cognitive impairments. Very important thing is traumatic brain injury, as we'll talk about, is also a risk factor for dementia, fatigue, irritability, anxiety, and depression. And of course, all of these symptoms can proliferate and become more severe as the severity of TBI increases and there's more evidence of structural damage. And so that's an important thing to note as well. CT imaging of TBI, why do we do it? We do it because it's fast. With these new generation CT scanners, we can get an image of the head in less than 10 seconds, super fast. MRI, on the other hand, can take, typically around minutes to a half an hour for most of the brain protocols, although some protocols are getting shorter, but not nearly as fast as CT. And the important thing to understand about CT is that we're using CT as a way of detecting really big, bad stuff that could kill the patient right away within minutes. So we're talking abnormally elevated fluid in the brain or hydrocephalus. We're talking about massive hemorrhage causing herniation and mass effect. And of course, fractures can be part of that. So we look for that too. But CT otherwise isn't sensitive for showing us a lot of information beyond these findings. And so, just like we don't use a chest X-ray to screen for lung cancer, we use CAT scans of the chest to screen for lung cancer. A CT of the head is like the chest X-ray of neuroradiology. There's really not much you can tell based on, these acute findings that I'm noting here. If there's a large stroke, you could possibly see it as well, but obviously, beyond that, there's a lot of small things or subtle things that you can't see, and that even no expert could see. And so when we see, for TBI, normal CT, That should not be reassuring unless to the extent that it did not demonstrate any massively acute emergent findings. And so I think that's really important context to establish there. However, MRI, and by that I mean conventional MRI, we're not talking about advanced sequences. We're talking about, and again, we're going to go through an alphabet soup of different types of sequences. There's fluid attenuation, inversion recovery, which is called the FLAIR sequence. There's susceptibility weighted imaging, which looks at hemorrhage. FLAIR looks at white matter or gliosis or scarring or demyelination. And even those conventional sequences are superior to CT for looking for subarachnoid hemorrhage. That's what the SAH stands for. And it's really high. It's 88% for MRI versus 75% for CT. So even for something that CT is good at detecting, like hemorrhage, MRI is better. And of course, CT is quite less predictive in mild traumatic brain injury, with only about 5 to 30% of scans showing positive findings. And so, what that means is if you have 10 people with mild traumatic brain injury coming in, no more than 3 out of those 10 would show positive findings, which means 7 out of 10 won't show anything. And so that's a very important context to establish when understanding the limitations of CT in TBI as well. And so this is an example of, these are all clinical cases that I'm showing you here. And so this is an example of an axial non-contrast head CT where you can see with the blue arrows, the suture lines that we can note. So you can actually have these little squiggly lines that are sutures. And we can see actually the sutures are in the kind of more turquoise line. And so this is kind of the more of the squiggly conformation. Fractures, on the other hand, these kind of sharp marginated lines, these are the blue arrows. And we can actually get imaging not only of the head with non-contrast CT, we can actually inject contrast or do magnetic resonance imaging to look at the veins of the brain. And the large veins of the brain are called the sinuses. And what you can see here is that when you have fractures of the occipital bone, as we see with the blue arrows, you can actually get lacerations, injury, and thrombosis, clots basically, in the transverse sinus here on the right-hand side. And we can see some cortical vein thrombosis as well. And so, again, you would need to do additional assessments, but that's an example of why it's important to pick up skull fractures, because skull fractures can lacerate vessels, it can contuse brain tissue. The skull has a lot of sharp internal bony ridges, and the brain and the blood vessels are very delicate. The brain itself has the consistency of soft butter, which makes sense because a lot of the brain is fat based on the myelin content of the white matter. And so it doesn't take a lot to cause damage to those areas. And when the brain is injured, it shakes around in the cerebral spinal fluid of the skull. There's no seatbelt to hold the brain stationary when there's a jolting force or deceleration force. And so that's why you can have these injuries so easily. And again, this is an example of a paper published back in 2014 showing that you can look at the pattern of calvarial or skull fractions on CT to predict the risk of delayed epidural hematoma. Epidural hematoma is when you have injury, typically to the middle meningeal artery, which can cause a massive, expansion and herniation. And so, what you're seeing here on part A of this figure off to your left is an arrow pointing to, an extraaxial hematoma, most often an epidural hematoma, although subdural as well is also the differential consideration. This looks here like a subdural hematoma in part A, but in part C, we have a different type of hematoma, which is more kind of bulging, more convex, and it's causing mass effect on the brain. This thin white line we see here is bowed outward to the right side, and that's not normal because we have a large hemorrhage, this kind of white and heterogeneous collection that's pushing the entire brain over to one side. And so that's an epidural hematoma right there. And so you can actually look at, calvarial fracture patterns. You can see, for instance, this laceration or this fracture here of the calvarial component in the occipital temporal bone area. And you can see another kind of, uh, convex bulging hematoma called an epidural hematoma in the kind of back part of the brain called the posterior fossa next to the cerebellum. You can see another subdural hematoma in part A of the figure. And these hematomas often coexist or they can be separate. And again, this is what CT is good for. It's showing you the fractures. It's showing you the large hematomas that could cause immediate, acute, life-threatening injury, right? A neurosurgeon is going to have to go in and decompress this. So that's what CT is really good for. And of course, we can tell all sorts of things based on this information, and that is important. But again, there's a much milder range of brain injury that wouldn't be detected or wouldn't be signified by these findings. This is more severe traumatic brain injury, for example. And of course, sometimes you can have, subtle soft tissue findings, right? And not everything from traumatic brain injury is intracranial. In fact, one of the most important clues is to look at the soft tissue windows on the non-contrast CT and ask whether or not there's evidence of, hemorrhage on the soft tissues or kind of outer surface and skin of the brain. And we see an example of that right here, where you see a collection of blood and hypodense contents. And this is over the kind of the vertex or the high part of the skull here on the right-hand side. With radiology, it's often opposites in terms of how we look at the images based on how they're acquired. And, a subgaleal hematoma is important to look at because it's essentially a collection of blood, between the bone and the kind of fibrous layer, which can then cause a lot of collection of blood. And so it is possible, if this isn't treated, for patients to exsanguinate through this actual kind of area of subgaleal hematoma. And so it is something that we mention when we actually read our scans, and we do notify clinicians about that too when they're quite large. This is another example of a subgaleal hematoma here that you're seeing kind of this collection of blood under the skin, under the fat layer, which is dark. The red arrow is pointing to the subgaleal hematoma. And then, of course, there's an associated subdural hematoma, which is, unlike an epidural hematoma, more concave, as opposed to bulging outward or convex that we see by the second red arrow. By far, when we're dealing with motor vehicle collisions, the most important type of mechanism that we see is called the coup counter coup injury. So what a coup counter coup injury means is if there's an initial impact to a certain side of the brain, let's say here we see this arrow, which could be, let's say, a direct blow, just for the sake of argument. Maybe it's in a motor vehicle collision when somebody's, head is hitting the back of a seat or a window or what have you, or maybe it could be a direct blow, and like in the case of assault, for example. And that direct impact is where the specific force is applied to. And so when that happens, that impact leads to a coup, which is essentially the underlying part of the brain related to where the force was applied is impacted, right? There's a concussive, direct externally applied force or traumatic force that's applied. And this red area that you're seeing here signifies the area of damage to that part of the brain, or how much of that brain is affected. However, the brain, like I said earlier, isn't just fixed in certain position. It's floating in cerebral spinal fluid. And so what happens is the brain shakes around in the skull. And so you see more CSF here, or this dark area, because the brain is shaking around and moving. It's moving inside the skull when this concussive or traumatic force is applied. And then what happens when the impact and the coup occurs is the brain then moves to the other side and hits the opposite part of the inner table of the skull, or the inside of the skull, in a sort of diagonally directed, motion from the point of the impact and the initial coup injury. And then that contralateral side of the brain, in this case, the left frontal lobe, is injured as well. That's signified by the second red colored area that you see. And what's interesting to note in this coup counter coup mechanism is that the counter coup part of the brain, the injury area there, is greater than the initial coup area of the brain, which may seem somewhat counterintuitive, because we all think that the worst part of the impact might be where the actual specific point of impact or blow is directed. But in fact, it's the contralateral side, or the counter coup area, that's often more frequently injured than the coup side. And so when we're talking about trauma, the coup counter coup mechanism is important to understand because it's super common. And at the same time, it can explain why we see frequent asymmetry and sometimes difficult to understand distributions and heterogeneity of traumatic findings, be they conventionally derived or examined with advanced imaging. And so, for example, right here we see evidence of trauma. This is an epidural hematoma with these two red arrows. We see this soft tissue hematoma as well, could be subgaleal. And so, there was a force applied which led to this hematoma. And of course, we're talking about here, the right frontal lobe. But that doesn't mean the left frontal lobe is okay. There could very well be injury there as well. But it's not always going to be as easy to see or as intuitive to see. And so, especially with advanced imaging, we can often characterize a greater area of abnormality than it's just what's derived from the original injury. And so long after this is resolved, on follow-up imaging with the right techniques, this contralateral area in the left frontal lobe might be quite abnormal, actually. And again, we can see that hemorrhage in the brain and severe TBI can go into all sorts of locations. It can be in the substance of the brain, the parenchyma. It can be extraaxial, which is kind of in the space outside the surface of the brain. It could go inside the fluid-filled compartments or cisterns of the brain or ventricles. And so you can see a lot of blood pooling here in the atrium of the lateral ventricles, the occipital horns, which can in turn cause hydrocephalus or abnormal expansion of the ventricles due to too much fluid, in this case, blood. And of course, those are important things to track because the brain is a closed compartment. There isn't any room for there to be extra things that aren't supposed to be there. And so that can cause herniation syndromes and death. And so this is the sort of severe TBI findings from which one would require, emergent intervention, either from a neurocritical care, intensive care unit, or else a neurosurgical intervention, or a combination of both. And of course, here we see another example. Again, we're just looking at CT scans right now. We're not even getting into MR so much, but this is what we typically find where you see what's called, parenchymal hematoma. And what you'll notice is that this parenchymal hematoma, this abnormally high, white signal here, this is in the, left frontal lobe. Of course, there are smaller cortical contusions in the right frontal lobe. And the frontal lobes are among the most commonly injured area in traumatic brain injury, uh, partly due to the way trauma just occurs with, uh, motor vehicle collisions and just the impact, distribution. The temporal lobes, which houses a lot of the key memory centers, just like the frontal lobes houses a lot of key executive functions, is also a very commonly injured area of the brain. And of course, this hemorrhage has edema around it. There's a little bit of mass effect on the lateral ventricles, which means they're being compressed. And so this is a quite abnormal finding. You'll also notice that, even though we have these frontal lobe contusions, if you look back here, there's another subdural hematoma and a little bit of hypodensity from damage to the brain compartment in the back. So again, kind of this coup counter coup pattern where you see front part of the injury and then you can see the back part is also injured as well. And so frequently what we'll see, you can see a little bit of subdural hematoma on the parietal lobe on the left side as well. And so we can frequently see injury to the kind of back part of the brain and the parietal lobe as well. We can see additional examples with these black arrows, from the literature of, hemorrhage accumulating along the cisterns and the basal cisterns in particular, going into the temporal horns. We can see subarachnoid hemorrhage. We can see a large parenchymal hematoma with these two black arrows on the right part of the figure. And so all these injuries can coexist at once, especially with severe trauma as well. And so I think that's going to be an important thing to examine. Of course, trauma doesn't just affect adults, it affects children, especially when we talk about, non-accidental trauma, abusive head trauma, which I don't recall if this is a case or not of that, but we do know that, trauma happens in kids for all sorts of reasons. And again, here we see, this kind of depressed skull fracture with a little bit of displacement of the bone outward. We can see, what appears to be an epidural hematoma based on the convex appearance. There's some soft tissue hematoma as well. And it's going again, we can see underlying mass effect in the child. And so that's also an acute traumatic finding. Of course, we see another example of a subdural hematoma. Some of these can be quite subtle. One thing you'll notice is that we not only see it here in the subdural compartment, but also if you look at this thin white line here, this is the tentorium cerebellum or cerebelli. We can see that it's a little thicker, a little white on the kind of left side here compared to the right. And that's because you can see distribution of subdural blood along the tentorium. And so this is a coronal image of the head where you're looking at the person kind of en face. And so when I teach residents, what I'll tell them is that this is an important area where you have to look because you can see missed subdural hematoma. Sometimes when the scan is called normal, it's not always normal. You can see subtle evidence of acute findings. And so that's really what CT shows you, right? Hemorrhage, skull fracture, hydrocephalus, herniation, maybe some hypodensity, especially chronically from severe traumatic brain injury. And those are the main findings that we can see with with CT. But there are a lot of things we can't see with CT. We can't see, for example, damage to the white matter that's very severe and yet difficult to appreciate. And the type that I'm referring to is specifically diffuse axonal injury. This is a graphic illustration of diffuse axonal injury. Diffuse axonal injury is when the acceleration, deceleration forces on the head, typically in like a car accident, but it could also be blast injury as well, conceivably. That's when you have a resulting, tearing or stretching of the axons. And so well, what are the axons? Well, the axons are essentially the white matter connections between neurons. And so this is the cell body right here, this kind of round area. You've got the axon, which is the kind of more linear projection. Here it's injured. It's not supposed to be discontinuous like this. And the red colors kind of denote that injury and hemorrhage. And then, of course, the kind of corresponding dendrites and synapses are what allow our brains to function, what allows neuronal communication to happen. It's what allows there to be connection between different cortical areas. And so why is it important to understand, evidence of white matter injury, whether it's diffuse axonal injury, which is the more severe version of that, or even mild white matter injury? Well, because when different parts of the brain can't communicate with each other because the white matter is injured, this leads to disconnection of those areas and then dysfunctional findings in the cortex of the brain. And so when we talk about, as I'll talk about in kind of the second part of this talk, abnormally low blood flow to the brain, um, or connectivity, some of that is direct impact to those areas. But some of it also is contributed by the fact that those brain areas won't be as healthy in their physiology or their brain structure if they're not communicating. And so the kind of classic principle in neuroscience is that neurons that wire together or communicate to each other fire together and develop and become stronger. And the ones that don't then become disconnected and weaker. And that can manifest in a variety of advanced imaging findings. But diffuse axonal injury is a severe manifestation of what we see in damage from traumatic brain injury. And that's not something that you can appreciate on CT typically. And of course, there are different diffuse axonal injury classifications. There's no consensus on any one you have to use. One can simply make the finding. One can use grading. And of course, in this particular grading system, which is the Adams system, a grade 1 injury can be a mild diffuse axonal injury with microscopic white matter changes in the cerebral cortex, corpus callosum, and brainstem. And the reason I say this, the reason I mention this is because grade 1 means one can have DAI that, gives you microscopic findings essentially, which means with grade 1, one might not be able to see this with conventional MRI sequences and such. So if the white matter changes are microscopic in grade 1, then one would need a micro or microstructural approach to examining the white matter. And when we talk about diffusion tensor imaging in part 2 of this talk, that utility will become evident. Grade 2 is a moderate diffuse axonal injury with gross focal lesions in the corpus callosum. Gross focal lesions means these are things that we can see visually on the scan. The corpus callosum is the inner hemispheric white matter commissure connecting the right brain to the left brain and vice versa. And so that's essentially very big lesions we can see in the largest possible white matter tract that we could see in the brain. However, as I'll discuss in part 2 of this talk, there are over 30 different white matter tracts in the brain that we can see. So just because you know just because you don't see any sort of traffic jam on the 405 in California doesn't mean that small side roads might not be blocked or occluded or otherwise dysfunctional. And so, you can't just limit your assessment of diffuse axonal injury to the corpus callosum if we want to be actually thorough and accurate. Grade 3 is a severe diffuse axonal injury with findings such as grade 2, in other words, gross focal lesions that can be seen on conventional sequences, with additional focal lesions in the brainstem. And I think the reason they talk about the lesions in the brainstem is because, of course, the brainstem also tracks major white matter bundles as well. And of course, injury to the brainstem often correlates to kind of long-term potential implications for coma, consciousness, arousal, and so on. And so, just to illustrate some of the points that I mentioned, this is a case of diffuse axonal injury. And what we're seeing on the left is an axial non-contrast head CT. And again, axial means you're looking top down. And it looks completely negative. A radiologist could look at the skin and say normal. But I don't like using the term normal for a non-contrast head CT because that suggests that the brain is normal and that there's no abnormality we could otherwise possibly see. And I don't think that's true because when you look on the right side, and here we're looking at an axial susceptibility weighted MRI imaging, and the way that image works is it emphasizes abnormal deoxyhemoglobin and iron changes, which then cause a signal dropout or darker signal. And when the dark signals are round, like what we're seeing here in the frontal lobes bilaterally, and when they're located in the white matter, as we also see as well, because of course the gray matter is in the outer cortex, this is what we see on MRI, on conventional imaging of diffuse axonal injury. And so again, we see that, and it wasn't evident on the CT at all. So again, I think that that's an important thing to note because it's possible to have normal CT that's hiding much deeper and worser injuries. And so again, this is diffuse axonal injury. And again, if we see this as kind of grade 1, it means that we can see some lesions, but there are obviously going to be some microscopic white matter changes that we can't see, kind of an allusion to my earlier discussion on the nuance of that classification. This is another example of diffuse axonal injury where we see injury to this kind of the left frontal lobe, which is really evident in these multiple kind of lesions in the white matter that are causing signal dropout. And again, this is blood. These are injured, bloodied axons in the white matter of the brain, which of course can cause disconnections, discommunications. And again, when it happens in the frontal lobe of the brain, some of the things that can result from that in the literature are executive dysfunction, difficulty in focusing on short-term tasks, and of course, this can have long-term chronic implications that, of course, neurologists and neuropsychologists can further assess. Okay, this is another example of a non-contrast head CT on the left side. And again, I would be hard pressed to note any abnormality. And the way I would read this scan is that I don't see any, visually evident hydrocephalus, hemorrhage, or herniation. But again, you can have hemorrhagic or damage to the white matter that is not evident on the CT. And so we can see that on the far right of the figure, again, the susceptibility weighted image with, the signal dropout, these kind of low circular areas of dark signal. And we can see this in the temporal lobes. And again, couple of things to note. Showed you frontal lobe diffuse axonal injury. I've shown you temporal lobe diffuse axonal injury. But again, those are some of the most common areas that are affected. It's worse on one side than the other, often a key finding. The middle image is the flare image, that fluid attenuated inversion recovery, which can show white matter gliosis, which can happen in diffuse axonal injury, but it can also be completely normal, completely invisible to the DAI that we see on the susceptibility weighted images. And so, traumatic brain injuries is, a disorder that requires complementary bits of information because no one imaging test or sequence can necessarily catch the full range of abnormalities and findings, which is why, as we'll discuss, there is benefit to looking at advanced imaging approaches. And again, with axonal injury, and this is a slide, that Dr. Mukherjee, shows in his talks. Again, just shows you an example where you can have a quote normal CT that we see in the bottom left corner. You can see abnormal diffusion signal. And again, when I talk about diffusion tensor imaging, there's simpler versions of diffusion weighted imaging. And what's diffusion weighted imaging? It's using an MRI to track the movement of water in the brain, which can be abnormal in a variety of conditions. And so, for instance, it is possible with acute diffuse axonal injury for one to see restricted diffusion, which is kind of this abnormal movement of water that we can note with these arrows. I don't see this finding nearly as much as abnormalities on diffusion tensor imaging, but of course, very acutely with traumatic brain injury, it is possible to see. It's a timing issue. If you don't get the diffusion weighted imaging early, you're not going to see it. And of course, we can see these kind of T2 gradient echo or kind of susceptibility sensitive sequences that also show evidence of the diffuse axonal injury with this white matter shearing blood and corresponding low signal dropout on these images. So again, just emphasizing that the normal CT can hide a lot of underlying abnormalities that even conventional MRI sequences can be helpful in characterizing. And of course, I alluded earlier to non-accidental or abusive head trauma in pediatrics. And again, we can see that there's susceptibility weighted image in a child, which shows diffuse axonal injury with the arrows, as well as just larger intracranial hemorrhages more posteriorly. And diffuse axonal injury is double in non-accidental trauma what it is compared to everything else. And so again, with adult head trauma, it's 14% in kids versus 8%. And so again, diffuse axonal injury, only 8% in adults. So what does that mean? That means that 92% of adults can have head trauma and damage from head trauma without diffuse axonal injury, which means that looking at these sequences and ruling out any head trauma if they're so-called normal isn't going to be enough to characterize abnormalities accurately in TBI, especially if there are milder degrees of head trauma that don't show diffuse axonal injury. Diffuse axonal injury is something you'll see more with like a severe head trauma, for example. Atrophy frequently occurs after traumatic brain injury, which makes sense because when there is damage from the brain shaking around and hitting the inner table of the skull, neurons don't like that. And when that happens, neurons get contused, they can die off, and you can have atrophy and surrounding scarring. And so we're seeing that here on these sagittal, axial, and coronal flare images. And again, sagittal, you're looking at the brain to the side. Axial's top down. Coronal is kind of looking at the person face on. And what we see is these crosshairs, which co-localize this area of frontal lobe damage. So again, this is the frontal lobe. This is right behind the eye. This is the eyeball right here. And again, we can see this kind of asymmetry, very common in TBI, where one side is often affected differently than the other side, even if both sides are affected. And so if something is affected on both sides of the brain and it's bilateral and it's looking the same on both sides, that's bilateral symmetry. You can have bilateral asymmetry where two sides are affected but not the same way. And then sometimes, although this is not quite as frequent, but it is theoretically possible, you can have completely unilateral asymmetry, but typically bilateral asymmetry is what we see in traumatic brain injury. Here, it just looks more unilateral, although I would argue you could see a little bit of gliosis on the left frontal lobe as well, which could also be from traumatic brain injury. But certainly we see this right frontal area affected, and you can have atrophy and shrinkage of the brain. Now, When the shrinkage is very blatant, where whole parts of the brain are missing, such that any human looking at it can look at it and say, yes, that part of the brain is missing, we have a special term for that called encephalomalacia. Okay, so encephalomalacia is essentially really severe atrophy where just blatant parts of the brain are just gone and completely replaced by fluid. But you can have atrophy and shrinkage of the brain that is more subtle and evident and measurable even before you see encephalomalacia. And so here in this individual who sustained head trauma, we have this area of right frontal encephalomalacia as outlined by the crosshairs. And of course, the publications on, traumatic brain injury, cerebral atrophy are numerous. We have one such example right here that was published several years ago. We can see manifestations of atrophy showing that it can involve multiple findings from widening of the cortical sulci, enlargement of the ventricles, thinning of the cortex. And we talk about this in Alzheimer's disease, but it's possible to see it in traumatic brain injury, shrinkage of the hippocampus. And it's probably one reason why traumatic brain injury leads to dementia with a higher rate, because shrinking of the hippocampus is a temporal lobe structure. And so, since the temporal lobe is one of the most injured places in traumatic brain injury, we would expect to see that there would be injury from that standpoint. It's also important to appreciate that traumatic brain injury is an epidemiologically recognized risk factor for dementia, or traumatic brain injury is a risk factor for dementia. Because if we look at this paper published by the Lancet Commission, and so the Lancet is one of these very prestigious medical journals, and they have these commissions of experts that meet to talk about various important questions in medicine. One commission that's been meeting now for several years and met most recently in 2024 published guidelines identifying risk factors for dementia. And what they base these risk factors on are the collection of calculated, risk factors from different epidemiological studies. And so there are these large cohorts of thousands of patients that are studied in all sorts of different, out longitudinal outcomes. Dementia is one condition for which there are multiple longitudinal studies and epidemiological studies that are out there. The Framingham study is a very good example of that. But there are many more, of course. There's the Alzheimer's Disease Neuroimaging Initiative, and there are, of course, local cohorts as well. And so they looked at all these different studies and they basically calculated across all these different studies, what is the percentage attributable risk for dementia from each one of a variety of risk factors. And they looked at it in early life, midlife, and late life. And so midlife is typically in the 40s and 50s. Late life is in the 60s, 70s, and 80s. And earlier life, includes, childhood to kind of early adulthood. And so, of course, early life, one of the biggest risk factors is lower educational attainment, big risk factor for dementia. Late life, we see things like social isolation, air pollution, visual loss. By far, most of the risk factors for dementia cluster at midlife, between age 40 and age 60. And so we can see things like hearing loss, we can see things like obesity, which I study a lot in my NIH-funded work, hypertension. But traumatic brain injury is at 3%. So that's a very big proportion of risk compared to a lot of these other factors. I mean, diabetes is a lower risk factor for dementia than traumatic brain injury. Smoking isn't as bad as traumatic brain injury for dementia risk. Even obesity, which I think is a very important risk factor for dementia, isn't as powerful a risk factor for dementia as traumatic brain injury. And of course, collectively, these risk factors across the lifespan can contribute to close to half of the dementia risk. So it's actually important to understand and to characterize these risks. And I think that's going to be super important. And so, we've talked about CT imaging of traumatic brain injury, MRI imaging, want to focus on diffuse axonal injury. We've looked at really severe examples, things that we can see visually. And so these are super important. But I'll just start with kind of a case that I had clinically recently. This is, de-identified, but we can talk about some of the history. This is an individual who basically drove her car into a bridge at unknown speeds, but it was thought to be high speed. had an ethanol level of 228, so some concerns about alcohol intoxication, had a Glasgow Coma scale of 7, so really getting more into that severe TBI category. And of course, had positive head strike and kind of a deformity of the left parietal scalp. And again, on a follow-up study, it was found that she had impaired memory on the short blessed test of memory. And she had a MoCA, or Montreal Cognitive Assessment Test, of 19 out of 30. So again, just going to the imaging, we see here that there's a soft tissue hematoma, almost 2 centimeters, so quite large, corresponding to the described physical exam findings of the kind of areas that were injured in the accident. We can see on the axial and coronal images that she has this area of soft tissue hematoma, but there's no evidence of intracranial hemorrhage. There's no epidural hematoma. There's no subdural hematoma. There's no parenchymal hemorrhage. There is a cavum septum pellucidum at Virgae, which is basically a split of this membrane that should be normally one membrane, and here it's two. That can happen with traumatic brain injury as well. Some would argue that it's developmental, but it could also be seen in TBI. We see on her sagittal and CT and MRI scans of her cervical spine a teardrop fracture at the level of C5 that we see in the arrows denoted on both images. And so this is a very severe form of trauma. This is enough to cause not just, that soft tissue hematoma, but also the spine injury as well. And if we look at her axial susceptibility weighted images, which were taken, in the same week of her injury, although I don't think it was taken on the same day, we see multiple areas of low signal dropout in the frontal lobes, as well as asymmetry in the left temporal lobe, indicative of diffuse axonal injury. And of course, we can see other areas, near the brainstem. We can see them near the temporal lobe as well on the right, and more so on the left. We can see even one lesion in the cerebellum. And then 4 months after her injury, she had another MRI scan done. And if you compare the kind of initial time point where we didn't have a complete, fully, analyzable T1 scan for measurable volumes, but we do see kind of the ventricles at this time point, and you co-localize it in the same area, and you just measure these little spaces here around the hippocampus. This is the hippocampus right here. You can see there's more fluid around the hippocampus 4 months later than there was at the initial time point, because you can actually measure the amount of fluid in between manually, and you can see that, in a similar way of measurement, there's larger areas around the hippocampus. So that's interesting to see. That suggests that there's been more atrophy or shrinkage of the hippocampus across those 4 months. But also, if you look at time 0 and 4 months later, and you measure the frontal horn diameter of the ventricles, again, these are radiologists. We do these measurements all the time. This is done in clinical practice every day. It's not by any means the most specific measurement one can do. And one can say that, it can be hard to get these measurements to be precise. But if we really try hard to measure these areas in a similar way as we're doing, there's been an 11% increase in the frontal horn diameter after 4 months. It was 29.1 millimeters at the time of injury, and then 4 months later it was 32.3 millimeters. Of course, we noted earlier the increased temporal horn width around the hippocampus. So what does this all mean? This means that there's been atrophy across those 4 months, because for fluid to expand in the brain by itself without anything acutely expanding it, like hemorrhage, which we didn't see any evidence of on the CT or the MRI, except of course the DAI, but with no actual blood in the ventricles to expand them, the only way you could have increase in these fluid spaces over 4 months is if there's atrophy that's taking place. Because when atrophy occurs, there's shrinkage of the gray matter, shrinkage of the white matter, for example, then fluid expands to fill that lost space, which is why this fluid and these measurements are bigger on the follow-up time scale. Now, this individual is 28 years of age. Nobody should be having any atrophy before age 30. And of course, when atrophy does begin at age 30, it's 0.1% a year, 0.1% a year, not even 1% a year, let alone 11% in 4 months. And so this is quite an impressive amount of atrophy for such a short period of time in somebody so young who shouldn't be having atrophy at all. Of course, on the follow-up times MRI at 4 months, we still see some residual evidence of the diffuse axonal injury as well. Of course, the spine looks a lot better since there's been interval healing of that teardrop fracture. And again, here I begin kind of this early introduction into advanced imaging to kind of bridge our next talk, where we have the ability to use any variety of programs, whether they're research or FDA cleared, to measure brain volumes. And these papers validating these approaches have been published by the thousands over the last 3 decades. So this is not experimental. This is not new. This is well-established work that's been replicated multiple times across multiple software platforms and multiple settings, including traumatic brain injury. And what we do is we take the individual scan, we process the scan to remove the skull, label and volumetrically measure the actual size of different brain areas, and then we can compare them to normative data to see if they're too big or too small. Of course, things that are too big that we don't want to be too big are the ventricles. Things that are too small that we don't want to see to be too small are the individual brain areas. So we did that in this case right here. That was done. We can see the actual areas of low volume that we're segmenting out. And we can graph the results on charts to measure how badly somebody's brain might be looking compared to normative data. And we did that for this individual for the left and right hippocampus. Now, this 28-year-old woman who got injured in this accident has a hippocampal volume percentile of 1 percentile on both sides. Now, usually when we see areas that low, that's an Alzheimer's disease. But of course, at 28 years old, she's too young to be getting Alzheimer's disease. And yet we see these low volumes, and these are due to the actual head trauma. We can see other areas of low volumes in the parietal lobes, the occipital lobes. The lateral ventricles are too large. The frontal lobes are technically in the normal range, but not as normal as they could be for somebody that's young. We can see it that if we take the ratio of frontal to temporal lobe thickness, it's also on the lower end of normal as well. And of course, if we isolate and look with z-scores, other brain areas, we can see that there are abnormally low z-scores. In the case of the actual parenchymal structures, less than -2 standard deviations from the mean. We can see the posterior cingulate is affected. That's an Alzheimer's hotspot. Other orbital frontal areas are affected as well. We can see the hippocampal volumes being pretty low, the lateral ventricle volumes being pretty high, especially on the left side, kind of speaking to the asymmetry of the findings. Interestingly enough, if somebody wanted to claim that all this volume loss was due to the alcohol use, that would not be something I could agree to, because if this atrophy was due to chronic alcohol use, we would expect to see the cerebellum to be abnormally low in volume, because the cerebellum is exquisitely vulnerable to chronic alcohol use, but we can see it's within 2 standard deviations from the mean. So this is not due to alcohol use. This is trauma. And again, we've talked about the high risk of dementia from head trauma across multiple epidemiological studies with varying high risks that are close to triple or more risk. We know that if you have atrophy in the brain and you have a genetically high risk of Alzheimer's disease, that atrophy will predict one declining to dementia faster. So having atrophy is not a good thing for brain health, especially if we're trying to avoid dementia. And if we actually ask the question, if this person were, 55 or older, and we fed her brain into an AI model that determined Alzheimer's disease, what would be the risk for Alzheimer's disease? The risk for Alzheimer's is approaching 81%. And we can see that high risk in these red colors on this 3D map of this individual's brain. And look at this. You can see if we stop the image, all the higher risk for dementia, in the red, orange, or yellow colors and green colors, is on the left side of the brain. And on that original CT scan I showed you, that soft tissue hematoma was over the left side of the brain. But also we have contralateral or counter-Q areas that are affected as well. And this asymmetry of high risk of dementia really speaks to the fact that we're dealing with the trauma pattern. Blue, on the other hand, is low risk. It's lower than 20%. If we look at this individual's hippocampi, these seashore-shaped structures, all that red here is a higher Alzheimer's risk, particularly in the front part of the hippocampus, which is where Alzheimer's starts. This individual is 28 years old. And of course, we can see the higher probabilities here at 81% or higher. Again, we would have to, input, the correct age to do this. And so this is more of a thought experiment than an actual conclusive data that we could show, because this individual is 28. And again, to be in this model, one would have to be 55 or older, which begs the question, how old does this person's brain really look? And we can also ask that question. We can actually look at brain age, comparing this individual's brain volumes to 40,000 scans and asking, how old does the brain look in this individual based on the size of these brain structures compared to what it should be across these large cohorts? And we can see this individual's brain, even though she's 28 years old, her chronological brain age is 10 years younger than her actual brain age, which was about close to 40. And so her brain age, estimated by the size of her brain structures on the aggregate, on average of all brain structures, is about 11 years older. But if you look at individual brain areas, which we can do with this software that we use in research, some of the brain areas approach 40 or 50. I mean, there are brain areas in the frontal lobe that approach a brain age of 61, especially in the left lateral orbital gyrus, which is kind of underlying that area of the head impact. You can see this diffusely throughout the brain. And so head trauma causes accelerated brain aging, which we can compute from brain age metrics, such as what we see here for the whole brain, but also more sensitively for individual brain structures. And again, we see that in this map right here, showing all this red. And all the red shows a brain age of around in the 40s and 50s, as opposed to 28, which is what it should be for this person's chronological age in blue. Note how the cerebellum has a normal brain age, which wouldn't happen if there was alcohol use. And so head trauma causes not only hemorrhage, skull fracture, but also elevated brain aging, brain shrinkage, and a higher vulnerability to Alzheimer's in the future. And these are just information that we can derive from a T1 weighted scan. And so when we meet next time, we'll talk more about advanced imaging techniques such as DTI and arterial spin label that'll add a lot more detail and sensitivity to what I've shown you today. Thank you so much for your time.
Thank you, Dr. Raji. Fantastic lecture as usual. We have a couple questions coming in on the chat. If you also have questions, go ahead and add them in now while I'm reviewing the ones that have come in. The first question is, excuse me, one second. This is from one of our researchers in the post-traumatic epilepsy group. She is asking if the CT MRI scans in the early phase, assuming acute phase of mild TBI, show nothing, but the patient subsequently develops post-traumatic epilepsy. Is it possible that CT MRI findings on subsequent scans would reveal abnormalities?
Yeah, I mean, it is possible if you show well, if they show nothing, I mean, it depends on how well you could match the findings of any advanced imaging abnormalities you saw with the EEG data. And so if the EEG data could be correlated to specific areas of abnormality in the brain on follow-up advanced imaging studies, that could represent a point of seizure. And so, for instance, interictal areas of abnormality might show lower blood flow, for example. And so that could be detected.
Thank you, Dr. Raji. Another question, general question. What is worse, an epidural hematoma or a subdural hematoma, and why?
Pick your poison. An epidural hematoma will kill you faster. A subdural hematoma confers a higher mortality risk overall, especially in older populations. And so neither one is desirable, with the context really determining how bad it is. I think Personally, I think epidural hematoma is the more dangerous of the two because epidural hematoma produces this kind of pseudo-lucid period where somebody will be injured and then they'll seem normal and then they'll just acutely decompensate and die. And so the actress Miranda Richardson, I think who is the wife of Liam Neeson, there was a lot of media stories about this in the 90s. She had a ski accident. She seemed lucid and then acutely decompensated and died. And that was an epidural hematoma, for example. So personally, I would say epidural hematoma is the worst, but technically subdural hematoma has the higher mortality risk overall.
Okay. We have another question, and I may help with this one and then add something to it for you, Dr. Raji. Is there a specific term for damage caused to the brain by surgery rather than TBI? The answer is yes. That's surgical brain injury. And of course, she's asking. I'm sorry. The asking also about tumor resection. And then, of course, you may want to add in neurosurgery, Dr. Raji, in terms of the additional injury secondary to the surgery.
Well, tumor resection is not something that we think of as a brain injury per se, because the idea is that even if you want to if one wants to remove a tumor and there's some surrounding gliosis that results from resecting the tumor, then the question comes, was that due to the tumor resection or was it due to the tumor itself causing edema and problems there? So that can be hard to determine. Sometimes in rare cases, and I only see maybe like one or two of these a year, you can sometimes get a stroke that develops around the resection cavity if something like that is complicating the surgery. But those are often small rims of stroke, which don't cause any mass effect or edema that lead to any severe consequences that we know of at this point. And so that would be kind of my answer to that. I wouldn't characterize them as traumatic brain injury in that sense.
Thank you, Dr. Raji. Next question. Is there evidence of plasticity, that would be neuroplasticity, to reduce the brain age through specific interventions?
Yes, there are all sorts of studies out there done showing that physical activity, which we've published on, and others have too, can actually improve hippocampal volume by promoting the secretion of neurotrophic factors such as brain-derived neurotrophic growth factor, and in so doing, actually lead to increased hippocampal volume over time. And so sometimes people will do what they call dual tasking, which is combining a physical activity with a cognitive test to engage both the brain and the body at the same time. And so these are popular interventions that are increasingly used in different specialty practices.
Okay. Great. And just a quick plug for our neuroendocrine group. Trey Wright is left, but with recombinant growth hormone, we published an increase in cortical thickness as well as gray matter volume and increased somatosensory network connections. So there are some specific interventions if there are definable clinical entities such as post-traumatic growth hormone deficiency as well. We'll do another lecture on that. Next question for Dr. Raji. I know you showed the cortex. Let me just see if I can read this. Sorry. I know you showed in the cortex that the risk for Alzheimer's seems to follow the trauma pattern. Does the hippocampal risk also follow the trauma pattern as well, or do you think they are related to something secondary that develops after the trauma, like hypoperfusion?
Well, I think that they probably all go together. If we look at um, looking back at the brain volumes, the right hippocampus actually had the worse Z-score than the left hippocampus, even though the initial head strike was happening on the left side. But like I also said, the counter-coup injury can lead to worse damage than the coup injury. So again, I think that to the extent that we can acknowledge that this severe TBI case had damage on both sides of the brain, then it follows the pattern of trauma that both sides or both hippocampi, right and left, are affected. And again, If we had advanced imaging, could we have seen more abnormalities? Yes, of course. But the point is, even with simple volumetric assessments, we can see quite a lot in severe cases. In milder TBI cases, we would certainly need the full range of advanced imaging to accurately characterize the abnormalities. But I think the moral of the story to take away from the case that I showed you at the end of the talk was one can't just look at the image and say, ah, there's mild atrophy, that's it. There should be no atrophy for somebody that young. And when we go deeper and characterize the brain volumes, we can see a quite extensive and concerning pattern of atrophy in terms of a higher future risk for Alzheimer's disease, as well as brain aging.
Okay, next question. I believe you said that the DWI, that's the diffusion weighted imaging hyperintensities, were only visible in the acute phase, maybe from intracellular swelling that resolves. Can you see the DTI changes in the acute phases as well, or do those abnormalities take more time to see or more time to develop?
Uh, you know, We don't often do DTI with acute phase TBI. When those studies have been done, they've shown actually elevated fractional anisotropy, which can happen with inflammation. It can happen with gliosis, which can also be a chronic process, and we've seen that. In terms of actually waiting for the chronic changes to evolve and you see more atrophy and dysfunction, you'll probably see more accumulation of abnormally low FA at that point, and we've seen examples of that in multiple cases out to several years. And so I think that you may not necessarily get the most straightforward interpretation of DT abnormalities in the acute phase. Most of the studies that have been published have been looking at it in the kind of more chronic phase, and that's why we get our understanding of the metrics from that data.
Okay. I think that's all of our questions. I'm waiting to see if anything else comes in. I think that's going to be it for today. We appreciate everyone attending. Thank you very much again, Dr. Raji, for your generosity today and in sharing your knowledge. We are going to have another lecture next week, which is part 2. That our normal time is on Fridays. We did this on Thursday as an exception for Dr. Raji. So next week, which is May 16th, I believe, is going to be Friday from 7 o'clock to 8 o'clock a.m. That's Pacific time, Pacific Daylight Time. And that's about it. So everybody have a great weekend, and we look forward to seeing all of you hopefully next week.